Hello, my name is Erin Hurst, and I am a nurse practitioner student at Auburn University. Today I will be talking to you about sodium glucose cotransport 2 inhibitors, otherwise known as SGLT2 inhibitors. The drugs in this class are empagliflozin, canagliflozin, and dapagliflozin. SGLT2 inhibitors block the SGLT2 proteins found in the proximal tubule of the kidneys. These proteins are responsible for mediating the reabsorption of 90% of the filtered glucose load. SGLT2 inhibitors block this reabsorption, leading to glucosuria and work independent to insulin with a low risk of hypoglycemia. To further explain the mechanism of action, we're going to go to Professor Hubble.
So this is your kidneys, bodily fluids, glucose found in your bodily fluids, and this is your SGLT2 inhibitors. Glucose and your bodily fluids in your kidneys. And then the SGLT2 inhibitors, get those out of bodily fluids, and those fluids return to your body and the remaining glucose spent through waste via the urine.
The therapeutic effects of SGLT2 inhibitors is to reduce the blood glucose level by increasing urinary glucose excretion via osmotic diuresis. These drugs have demonstrated the ability to decrease hemoglobin A1C levels by 1%. The pharmacodynamics are the inhibition of SGLT2 proteins, which lower the reabsorption of plasma glucose concentration in the kidneys due to increased urinary glucose excretion and reduction in plasma glucose levels in type 2 diabetics. SGLT2 inhibitors have a peak plasma time of 1 to 2 hours with an elimination half-life of 10 to 19 hours. The major site for drug metabolism is the liver. SGLT2 inhibitors are extensively protein-bound and are excreted via a combination of feces and urine. SGLT2 inhibitors cause a mild degree of dehydration, so use caution when prescribing these drugs in conjunction with other medications or with comorbidities that may predispose patients to acute renal injury. Use caution in patients with a predisposition for bacterial UTIs or GU yeast infections and those at high risk for falls or fractures. SGLT2 inhibitors are contraindicated in type 1 diabetes, in the presence of severe renal impairment, end-stage renal disease, or dialysis use, and in ketosis-prone type 2 diabetics. Canagliflozin is pregnancy category C. The remaining drugs cannot rule out fetal risk. Adverse drug reactions include GU tract infections, hypotension, bone fractures, amputations, hyperkalemia, and euglycemic diabetic ketoacidosis. Symptomatic hypotension is especially prevalent in older adults and in patients taking diuretics, ACE inhibitors, and ARBs. Euglycemic diabetic ketoacidosis, in which the blood glucose is less than 250, has been reported in patients. Canagliflozin has a black box warning for increased risk of toe, foot, and leg amputations in patients with CVD. An increased risk of bladder cancer with dapagliflozin has been reported, but is currently under post-market surveillance because of a lack of clear evidence. Patients taking SGLT2 inhibitors have a 2 to 4 time increased incidence of vulvovaginal yeast infections, as well as an increased risk of UTIs and potentially fatal urosepsis, pyelonephritis, and necrotizing fasciitis of the perineum. We're going to go back to Dr. Hubble to get a little bit more information about this.
Hey guys, it's Professor Hubble again. So I just want to talk to you about this drug. It increases the amount of glucose in your urine, which causes microbes, bacteria, yeast, and other things to be drawn to your genital areas, much like how honey attracts ants. This bacteria and stuff will cause different issues in your nether regions, like yeast infections, urinary tract infections, necrotizing fasciitis, and vulvovaginismus.
Drug interactions vary by the specific drugs in this class. Common interactions include decreased effectiveness with concurrent use of systemic or inhaled steroids and luprathiazide diuretics. SGLT2 inhibitors may become toxic when taken with barbiturates, MAOIs, salicylates, and potassium-sparing diuretics, and these drugs increase the effectiveness of digoxin, duloxetine, ACE inhibitors and ARBs, and hyperglycemia agents. SGLT2 inhibitors are not considered as initial therapy for the majority of patients and are not routinely recommended for patients without heart issues. SGLT2 inhibitors are especially helpful in patients with CVD who are not reaching glycemic goals with metformin and lifestyle modifications, who refuse injection therapy, and in whom weight gain and risk of hypoglycemia are significant issues. Empagliflozin should be the first choice in patients with a history of MI or CVAs. Although canagliflozin did show the most benefit in CVD patients and had the highest hemoglobin A1C reduction, it also showed an increased risk of amputations. Dapagliflozin should not be given to patients with active bladder cancer. All drugs in this class have differing GFR restrictions, and this should be considered when prescribing. In patients without CVD, the choice of SGLT2 inhibitors is dictated by cost. Prior to initiating therapy, assess volume status and renal and liver function. When starting in patients using insulin, sulfonylureas, and glycides, closely monitor blood glucose levels. During treatment, monitor the hemoglobin A1C and renal function. Any patient taking SGLT2 inhibitors that presents with nausea, vomiting, or malaise need to have serum ketones assessed immediately. Important patient education includes developing a hypoglycemia treatment plan for patients, including a planned insulin reduction schedule. Canagliflozin needs to be taken before the first meal of the day and taken at the same time every day. The remaining drugs in this class can be taken without regard to food or time. Lifestyle modifications include stressing the need for quality genital and perineal care, as well as the importance of quality foot care. SGLT2 inhibitors have an osmotic diuretic effect, which may lead to episodes of incontinence. The main takeaway for SGLT2 inhibitors are that they all end in gliflozin, so that's one way to remember them. Empagliflozin is a recommended drug of this class. It does not have the increased risk of amputations present with canagliflozin. SGLT2 inhibitors have been shown to decrease CV mortality and morbidity in patients with type 2 diabetes, reduce hospitalizations for heart failure, and appear to have a renal protective effect. Patients may experience euglycemic diabetic ketoacidosis, so providers and patients need to be aware and alert for the signs and symptoms even in the absence of elevated glucose levels. Patients are at higher risk for UTIs, urosepsis, pyelonephritis, and perennial necrotizing fasciitis due to an increased amount of glucose in the urine.
That's not lemonade. That's not lemonade.